Hello, and welcome to the MMRF Patient Webinar Series brought to you by the Multiple Myeloma Research Foundation. I am Ann Quinn Young, Chief Mission Officer at the MMRF, and I'm joined today by a very, very special guest, two-time 30-year cancer survivor, author, MMRF founder, and dear friend, Kathy Giusti. I had the extraordinary privilege of working side by side with Kathy for more than 20 years, and she continues to mentor and most importantly, inspire me every day to urgently pursue our mission. Today's webinar is focused on optimizing decision-making and planning throughout your disease journey. I'm very much looking forward to tapping into Kathy's expertise as, again, a 30-year cancer survivor who also built the largest, most impactful myeloma foundation in the world, while over the years personally helping thousands of cancer patients, not just multiple myeloma, but all cancer patients, optimize their journey. So for those of you who may not be as familiar with Kathy, her work and our work at the MMRF, Kathy spent nearly 3 decades transforming the way patients live with and fight cancer. She's a 2-time cancer survivor, healthcare entrepreneur, and former senior fellow at Harvard Business School. But she's best known as the founder of the MMRF, which again is the largest myeloma foundation and one of the most innovative disease-based research organizations in the world. We're here today because she recently wrote a book, Fatal to Fearless, 12 Steps to Beating Cancer in a Broken System, which draws upon her experience as both a patient and a founder. She's now a nationally recognized advocate for patient empowerment with a mission to give every patient a fighting chance. But before we launch in, I do need to cover a few housekeeping items. First, if you need technical support during the webinar, you can call the technical support line. The number is here, 719-234-7952. You can also, I can see already in the Q&A, if you indicate your issue in the Q&A, we'll make sure that that is addressed. There are also several resources available for you to review or download at any time during the webinar. There's a resource tab that includes our bios, as well as a copy of the few slides that will be covered in the before and after our chat. The exhibit hall also links to additional resources from the MMRF, as well as sponsor exhibitor booths. There's downloadable resources that you may find are complementary to the content today. So feel free to peruse the exhibit hall anytime during the webinar. At this time, I also want to thank Kite, Arcellx, and Cure Magazine for providing support for the series, which allows us to offer these and other educational programs to myeloma patients and caregivers at no cost. In terms of the question, I see a number of you have already started to input questions. If you haven't figured out how to do that yet, you can insert a question or a comment. Again, if you're having any challenges with sound or other technical issues, you can put that into the chat and I'll make sure that they're addressed. So feel free to submit questions anytime. We'll do a formal Q&A after Kathy and I have a bit of a fireside chat. So queue up then, now all the way back to then. A little bit more background about the MMRF. Since Kathy started the organization back in 1998, and I've been here almost all of those years as well, our mission has never, ever changed. It is to accelerate a cure for each and every myeloma patient. And from the time I joined this organization 23 years ago, it was very clear we would not hesitate to close our doors the day every patient is cured. In the meantime, though, to achieve that mission, we have 3 strategic priorities. The first, and this has been true since the day Kathy started the organization, and that's to accelerate the development of new treatments to make sure that patients always have treatment options. And we primarily do this today through our venture philanthropy fund called the Myeloma Investment Fund, where we're taking equity stakes in biotech companies that have potentially transformative treatments for patients. The second way we do this is to advance more personalized treatment options. We know this disease differs from patient to patient. So there's no one-size-fits-all treatment approach for every patient. So we have, for the past over 20 years, been building large data sets to represent the spectrum of myeloma patients, and then sponsoring clinical trials as well to understand which treatments work best for which patients. And then finally, as we do with the webinar today, we are committed to empowering patients in the entire community so that every patient and caregiver, every healthcare provider has access to resources, support, education to get the best possible outcome. Again, this webinar falls into this category, and I'll cover some of the other resources at the end of the webinar. In terms of today's learning objectives, typically, for those of you who have been on our webinars before, we have doctors showing data, slides. We're not doing that today. Today, we'll be specifically discussing strategies to best prepare yourself for key milestones in your disease journey, drawing upon Kathy's personal experience with her own journey, as well as, again, working with thousands of patients at every single point in their journey. And as I mentioned earlier, we will leave plenty of time for Q&A after the discussion. So we're hoping by the end of this webinar that you'll be able to identify what those key decision points are along your journey, understand what information and support are most important in that time, primarily so that you can plan for that next point in your journey and you're prepared should anything change. We also want to help you build confidence and agency, learning how to ask the right questions of your healthcare team and consult the best resources to guide those decisions. And finally, understand when to speak up and how to access the tools and support needed so that you can manage both disease-related and psychosocial challenges. So with that, we'll dive in. So Kathy, let's start with an evolving area, but also where you started with your journey, smoldering multiple myeloma. You smoldered for 9 years before your disease went active. And we hear all the time from smoldering patients, it's stressful. They're waiting for the other shoe to drop. They don't know when the disease is going to be active. Yet and we can talk a little bit about this too, it is a very heterogeneous population. Most smoldering patients should not be treated. So what did you do to stay on top of everything that was going on at the time? To be ready when your smoldering myeloma potentially turned into active myeloma?
Diane, first of all, it's great to be here. Thank you so much for the opportunity. And I just want to do just a bit of a preamble that, let's face it, I was diagnosed 30 years ago. So the world has changed so dramatically from the time that I was diagnosed, as Anne said, as a smoldering multiple myeloma patient. But I think the most important thing to know, first of all, is back then, they had trouble defining smoldering. So there's always uncertainty. I just feel like whenever you're dealing with myeloma or any cancer, there are always so many gray areas. So for me, what I ended up doing was saying, okay, some people are calling me smoldering. Other people are calling me stage 1. I couldn't get consensus on what the staging was. And then back then, stem cell transplant was just emerging. Some people were saying, wait, others were saying, no, you've got cancer, you've got to go right away. And so I feel like we've always had these challenges as patients, as you get more information, but it still comes back to being your decision. And that feels a little onerous at times. So for me, what I ended up doing was what I always tell everybody to do: you've got to do the research. So even back then, I was on and looking to say, okay, well, what centers are specializing the most right now in smoldering myeloma? And what exactly are they saying? And it turned out, back then there weren't as many centers. So it was the Mayo Clinic. They had an entire database that Bob Kyle and others were keeping on smoldering. And they were doing additional testing as a clinical trial on smoldering patients. So I was able to get that additional testing done. And that was a huge help to me in understanding what I should be doing when. So my response back to your question is, number one, you want to get every test done that you possibly can as your baseline when you are a smoldering patient. Number one, so they can define if you really are smoldering. And now in today's world, to define if you are considered to be high risk smoldering. And I say get every test you can at baseline because for me, I smoldered for a number of years. And a lot of people, another gray area is, am I moving, forward? Is this bad or is it not? And for me, I was lucky. Like a PET scan lit up, my M spike went up, everything just started to go really fast. I knew it was time for treatment. It's not always that easy. So I feel like when you are smoldering, get the best test, understand your risk, understand what treatment options you would be prepared for. And that, again, means doing the research to understand, are you going to just do a single drug? What would it look like? Which one would it be? Because these issues are changing over time as we speak. And then the other part is I had very different responses in how frequently to get monitored. I think that's a personal decision. They were like, oh, you can come in every 4 to 6. And I was like, no, I think I'll come in every 2 to 3 months. And that was just my own decision. Again, you're going to be going through all this anxiety and the things of waiting for tests more frequently. But in my type A personality, I wanted to keep close track of when this disease was moving. So those are some of the ways I dealt with it.
And one question that I don't think is discussed very often with smoldering patients is the role of a second opinion. And I know your stance, we at the foundation feel very strongly for active myeloma patients to seek a second opinion for a number of reasons. What do you advise smoldering patients to do?
Well, you know this about me, and I kind of advise second opinions in multiple places in the myeloma journey now, just because the science is moving so fast and so much of that science is happening at the major academic centers that you want to be talking with somebody there if you can to understand your next step. But certainly on the smoldering part, because I think understanding if you're high risk and understanding what you might go on, there's still different points of view on that. So I think you want to make sure that you're getting the best information you possibly can. So I am a huge fan of second opinions. I know it's so funny that in today's world, some patients still feel like that's an insult to the first doctor that you're seeing, that you're going to go get a second. At this point in time, it's just kind of routine. Doctors don't take this personally, but look, less than 50% of patients go to get a second opinion. I think it's crazy.
And another question we get all the time from patients, particularly calling into our patient navigation system, is managing the stress and the anxiety of a diagnosis of smoldering. And because smoldering is so heterogeneous, some patients may never progress, other patients may progress quickly. So that there's sometimes the most stress and anxiety at that point before there is even cancer. What did you do to manage that stress or anxiety? What advice do you have for patients in that situation?
Well, I think in situations like that, you have to optimize your own journey. So you have to say, am I getting monitored as frequently as I can? Am I staying on top of the information? If I went active today, would I know exactly what to do? So that having that plan in front of you would help you dramatically. Am I talking to other smoldering patients and knowing what they might do? Am I listening to the ASH meeting and getting the latest update on what's happening in it? So there's this element of staying on top of your game on the science side. But then there's this other element called living your life. And I think in that situation, and you know this about me, Anne, like it's hard not to be nervous about it, but it's not going to get you anywhere. Then it doesn't help you at all. So at some point you just have to say to yourself, I need to stay focused on the things that matter to me. And for someone like me, as you know, I was always journaling, and that was always my mainstay of what do I really need to be focused on right now. And typically having 2 little children when I was diagnosed, that was going to be not only my North Star, but probably my distraction of making sure I kept going and stayed focused on what was important to them. And I think you need those diversions. And, I talk about this a lot too, that there's the element of who's helping you on the caregiving side. It's going to be a partner, potentially a son or a daughter, but you don't want to put all that anxiety and your fear in them. Pick one person that you can talk. For me, that was my sister, because, she understood the fear, but you have to bring in your friends and other people that can be helpful too.
And certainly if you need professional help, one thing that always makes me a little concerned is when patients are asking to start treatment when they don't need it yet, because that anxiety versus getting the support they need, finding the distractions, finding others to help them through it. The answer is not to start treating myeloma that doesn't need treating.
Well, I think also, what you're balancing in a situation like that, and, we did it well, was the more time you're buying, that you're not on treatment, the more your questions are getting answered.
Mm-hmm.
So, like for right now, if you're a smoldering patient and you may say, well, am I high risk or am I not high risk? And then you're saying, do I want Revlimid or do I want Dara? Like that information is going to be coming available. So the more time you can buy not on treatment while you balance your risk level, the more you're going to have an answer to your question. And I think that's the game that we're all playing in the world of myeloma. That's why I always say, like, have a sense of what you think you might do by talking with your doctor, because I feel like you make the best decisions when you're not in a panic, that you're doing fine. That's the best time to be asking them, if something happened, what would you do? And if they respond like, don't worry, you're fine, don't let them get away with that. Say, right. No, I really need the answer to this question. I'm serious about it.
And so at that point, whether you're smoldering, converting to active myeloma, or just given a diagnosis of active myeloma, and you need to, in some cases, need to start treatment quickly and don't have a lot of time to do what you said. In some ways, smoldering is a gift, I guess, because you do have the time to learn the disease, learn the options. Some patients get diagnosed and have very aggressive disease, need to make a decision. How do you compress that educating and yourself and planning when you have very little time?
Well, I think you have to know the resources that are available to you. So first off, that I recognize that every patient is going to get this information in their portal. It's going to be, we suspect X, Y, or Z. And you're going to be sitting at your computer and your doctor is in the clinic. So, at some point you're going to take that information, hopefully word for word. And before you would have put it into Google, now you're probably putting it into ChatGPT. And so we have to face the reality of that. It's not a negative. It's not a negative at all. But these newly diagnosed patients perhaps aren't used to using ChatGPT for healthcare information. And so they may not know you need the most recent information of peer-reviewed journals. So that's when I think it's really important that patients understand you can start to get your information. You can go back and forth asking questions on your portal. I always put things in writing on my portal, because as soon as something's in writing, it's now in your medical record. So if you have questions and they need to get back to you on something, at least you put it in the portal. Then you go to ChatGPT, you're starting to learn things. Hopefully, by the time you're learning, you're actually realizing there are patient organizations and leading academic centers out there for you. Once you're learning that, again, you're going to call, hopefully, to the resources available to you, the MMRF, other organizations out there in blood cancers too. So you have to keep building that resource level, but that's just a logical way to work for someone like me who has amazing hindsight. It's not necessarily the way it's happening. So this is where I think the MMRF and everybody has to be aware of how we educate the patients, which is just because you get diagnosed with a specific cancer doesn't mean that the relative or the friend that you immediately jump on the phone with who had a different cancer is going to tell you to go to a center that may or may not be right for you. And so I feel like that's a little bit of why I live on social media, and is to try to educate people, like, not every cancer is the same. Not every cancer center is equally as good at one cancer versus another. And I'm constantly saying to people, whether it's myeloma or breast cancer or prostate cancer, there are amazing disease-based groups out there that actually can help lead you through this process. And they're not going to turn down your ChatGPT. They'll just help you to learn how to use it better and wiser. And the other thing I always say to everybody is your first visit with the oncologist, you will get more time for that visit, because that's your very first visit. They will put more time in the schedule for that one. So the more you can come in prepared with your questions, the better off you're going to be. Bring somebody in with you to hear the whole thing as well. But after that, it's 15-minute increments that we're typically getting. So you really have to start to get a sense of what you want to know and what decision you want that doctor to make with you that day, as opposed to asking them about your schedule or insurance issues or things the front desk could answer. Do not waste your time. That time is so precious for a decision on your treatment.
And we do tell patients, because right now in myeloma, there's not necessarily a right answer at any juncture, whether it's your treatment for first line, second, third, but for patients to be very clear about their treatment goals. Because otherwise you could spend half your time just going through the 5 different options there are for second, say you're on your first relapse for second line therapy, versus being able to articulate your specific treatment goals kind of helps steer the conversation in that way. So you mentioned the first visit, there's a lot of time, second, not so much. So how do you advise patients who may be experiencing, you have a short visit, you're experiencing some severe side effects, but also balancing how much do I really want to say because the treatment's working, and should I really be honest and share what's going on? Because what if the doctor, stops treatment or changes the dose and my disease comes back?
Well, I think at that point you have to be brutally honest. I think number one, you can do enough research to understand the drugs that you're on. I always say to everybody, like, when you're very first diagnosed and you're using resources, I wouldn't necessarily go to the pharma sites because, again, that's a commercial information. But when you actually know what you're on, that is a good time to go to the pharma sites because some of the side effects that you're facing are transitional. They may happen for a certain period of time. But I also really remind patients that if you come in and you understand the side effect and you understand the drug, you don't have to be a clinician or a pharmacist to do this. It doesn't have to be all or nothing. There's a word called titration. And, that's what we had to deal with all the time is you have your own, a 4-drug regimen as a standard of care, adjustments may have to be made. And even though it's a 4-drug regimen, you can replace a drug with another drug. So it's not like they're going to stop you. They won't necessarily stop you. They'll just make life better for you. So why would you not say something? And I think the other part is that we don't want to be a burden. We don't want to complain. We want our doctors to like us for whatever reason. And that's where I find bringing in a caregiver, somebody that's working with you and sees you day to day, to chime in is really important. And also just to hear what the doctor's recommending in terms of how to manage those side effects and how to deal with them.
And caregivers are more and more important, particularly with some of these treatments that have neurological side effects, where the patient may not even realize what they're experiencing. And so I think that shift has been interesting, where the doctor is asking the caregiver much more about the patient and trying to identify side effects than ever before. So caregivers, I do think, are more important and than ever before.
Well, all of these things, there's the scientific reason of why you pick a treatment with your doctor, right? And that makes sense. You're going to look at that. But from the scientific standpoint in myeloma, we still have a lot of good options that some doctors would say they're equal. Mm-hmm. So when you actually have to make that decision, it becomes, well, where is the treatment accessible? Can I even access that treatment at my hospital? How far do I have to go to get that treatment? The second is, do I have a caregiver? I mean, some patients don't. Do I have somebody that's going to help me get through this process? That immediately may change your situation. The third is, am I working? If I'm working, like, how much time can I take off? Is this scary for me to do? And so these elements keep coming into play, and it ends up being such a personal decision, what you're deciding to do, because you have opportunities and we don't know which one's better for you quite yet. We actually know there's several that are quite good for you. And I think that is what becomes the biggest challenge. And I know you and I have talked about this before, but the biggest challenge that caregivers have right now is the fact that it's now shared decision-making. The doctor is saying to you, here are the options. What do you want to do? And you're not sure. And the first person you're going to is probably your closest caregiver. And now they need to understand the options. And they're not scientists either. And so they get overwhelmed too. And I think this whole area of learning the science is really a big challenge for everybody, and why organizations like the MMRF and the navigation team play a really important role. To have a sounding board, to talk to before you go in with those 15 minutes with that doctor.
Well, and sometimes the caregiver may think a patient, you've seen this many times, should go a certain direction that the patient doesn't want to go. The caregiver, I think transplant is an example I hear still frequently, where the data still show that your best chance of a longer remission is with transplant. Now, the overall survival may not be there, but that progression-free survival, that time without disease, is has been proven. Yet there are options. So some patients don't want to go through. It was awful to go through that high dose chemotherapy. Yet the caregiver may say, "Why wouldn't you do that?" That's where the data say you should go. So I do think it's a conversation too, being very, as you said, brutally honest with your doctor, but also with your caregiver to say, "No, this is what I want to do. That these are my treatment goals. This is a path I want to go. Please support me with this."
Yeah, it's a fine line because often the caregiver has a good read on you and has some really good ideas, and at the same time, you know in your heart what you want, and the answer is usually in the middle.
Yeah. So we have this psychological kind of thread throughout. One thing that's changed too is now there's fixed duration therapy. So for decades, right, it was continuous therapy because there were so few options that patients were just treated till disease came back, treated till disease came back. Now with CAR T, you have that treatment-free interval. Some of these other immunotherapies, same thing. Even seeing transplant, you're MRD negative for 2 or 3 years, that's a good predictor of your prognosis. Yet we still hear patients are worried about stopping treatment, even when the data say they can. What advice do you have for those patients?
Yeah, so I was very fortunate. I mean, I did my stem cell transplant. I had a couple of years and then I relapsed. And then I went back in and I did donor lymphocyte infusion and Revlimid with my sister's cells because we were twins. So that made it better. And then I stayed on Revlimid for a certain period of time. For me, the issue back then was I was getting sick all the time while I was on Revlimid and maintenance therapy. And every time I got sick, I'd have to go off the drug. And I felt like I was off the drug more than I was on the drug. So because I was like a patient of one doing a clinical trial up at Dana-Farber, back then we didn't have MRD testing. So I was doing PCR. And so by doing PCR, I felt like, okay, I'm going to just see how deep my response is. And I'm going to be, again, this was my own personal decision, I'm going to be monitored closely. I'm going to try and do what I can as frequently as I can so that if something happens. So I did, transplant, stayed on maintenance, had a small relapse, went back on maintenance plus Revlimid with the DLI and Revlimid. And then, I said, okay, now I've been on Revlimid again for a few years. I'm going to go back off based on the PCR results. So that was highly effective, and that's where a lot of patients are going today. Here's the takeaway on this. Patients forget how these drugs affect you when they've been on them for a really long time. And then all of a sudden, when you're taken off of them, you go, oh my God, like this is an amazing feeling to be on a drug holiday at this point in time. And I do think that's a gift. So in my mind, now that we have really good information that if you have a deep response and you've been on maintenance for 3 years, just remember you can go off and you can still be monitored closely. And I think it's just a great gift we can give patients. We have worked really hard in the myeloma community to get to this point to say we want you to get off treatment. We really do, because it's better for you. And so I'm a huge fan of these trials where we actually learn something critical that's in the patient's best interest, and I would go for it.
No, it is such a wonderful shift that in the beginning it very much was just keeping patients alive because most patients didn't survive 5 years. And now we're at the point of, as you say, like living your life. You don't have to make that choice. There's still some very high risk patients who have to follow somewhat of a different protocol, but for standard risk patients, you don't have to make that choice between being on therapy that can be very toxic and living your life. You can have both.
Yeah, and I think that was pretty much the whole point of why I ended up writing the book I wrote, which was after reading 30 journals back, I think my biggest takeaway, and again, I was in an extreme situation where I was running the MMRF and everything was about urgency, and I was always fearful that we wouldn't have the next drug when I needed it, when every other patient needed it. And so you create this urgency, and my takeaway from having done that was then going, I was definitely staying alive, keeping myself alive, but I wasn't living. And I was missing out on so many things with my own family that I had a lot of regret about that when I went back and wrote the book. So I think that's why I wrote it, was to try to explain to people when you get these gifts of being able to get off therapy and do what you want to do, go travel, go see the world. Like, I don't care whatever it is, but pick your North Star, but go do it. Because no matter what, life is short.
Mm-hmm. So we talked about a bit about monitoring from smoldering to active, even once your disease is in remission, and just staying on top of any potential relapse. There's also the issue of second cancers, both ones that could be caused by, or the risk is increased by certain types of treatments, we know with myeloma. But then given the average age of a myeloma patient, individuals develop other cancers, whether it's breast or prostate or some kind of melanoma. Based on your own experience as having both myeloma and then diagnosed with breast cancer, what guidance do you have for patients in terms of not just monitoring their myeloma, but for the potential for second cancer?
Well, I think first of all, you have to identify by talking to your doctors, what is your risk of a secondary cancer or a second cancer, just because you are getting older, and actually having that discussion with them. You know this about me. I, for whatever reason, did not know from my primary care or my myeloma doctor that when my sister had stage 3 breast cancer and we're identical twins, that automatically put me at high risk. I should have known that. I think it's pretty obvious, and I was embarrassed that I didn't figure that out. But once you know that, now your whole protocol changes. A high-risk patient, when it comes to screening, is going to be treated differently. So I went from just seeing a regular OBGYN to seeing a breast surgeon because I needed to get there and they would monitor me. Then I had to switch from just doing mammogram to doing a mammogram in January and an MRI in July. That is what saved my life. It saved my life that they were able to find my breast cancer very early, because when you have myeloma and you've had radiation to the chest wall and the ribs, you are at high risk of breast cancer. So, and again, I was getting older. So, it's likely that you are going to get breast cancer as you get older. But I say the same thing, like I dodged these bullets. In myeloma, it was somewhat lucky because I was diagnosed smoldering on a routine blood test. In breast cancer, I was diagnosed early because I got on my game thanks to Keith Stewart and knew, okay, I'm at high risk. I got to switch my protocol here. But today's world now, what I do is I say to myself, I'm still at risk because I'm older and I'm dealing with these things. So I don't miss a dermatology appointment. You see them every 6 months. You have to. Do not miss that. When I did colonoscopy, polyp found, you have to go back every 2 years, not every 5 years. Like, you just have to do what they say and don't miss that screening. So every time there's an opportunity for you to get a potential screening, you need to know what every single one of those are, and you need to make sure you're talking to your doctors about it. If your primary care isn't covering that with you, that's a problem. Like, because again, we all need these survivorship plans. We don't really get them, but you have to understand, like, you can get something because we definitely have weakened immune systems. We're going to be more prone to it, and we just have to be aware of that.
And when patients are diagnosed with another cancer, it was clear in the book, but also certainly knowing your situation, I think you have some important advice for patients and how to coordinate that care, because it's hard enough coordinating your myeloma care, particularly if you have a local doctor and a specialist, another team. Now all of a sudden you're adding another oncologist to the team. What do you suggest patients do to make their life, it's already difficult, but as easy as possible to coordinate that?
It was one of my regrets, for sure. It's getting easier today because they are getting Epic to a better situation where people can download from different hospitals. But for me, yes, I was being treated at Dana-Farber for my myeloma, and then I had a local oncologist at Stanford Hospital in Connecticut. And that worked pretty well. Now those two hospitals are working together, which makes it a lot easier for myeloma patients that end up with that same duo. But when I got breast cancer, I decided to try New York. I had met a lot of the surgical oncologists there when I was helping my sister with her breast cancer. But the problem I ran into was those doctors weren't talking. Like, they would maybe have a quick conversation, but there was no real discussion when I was headed into surgery and other things were happening. And again, when you walk into an office and you look otherwise young and healthy, people really think you are. And what they don't understand is we have lousy immune systems. So what should have been a routine, somewhat routine as it can be, double mastectomy for me became an 18-month ordeal with multiple surgeries and really challenging infections. And I think looking back on it, if I had pushed harder and had those doctors working together better, I would have went on IVIG and I would have taken a lot more precautions in understanding my risk of infection, which was really quite maddening. And so I feel anytime you can find good doctors within the same medical system where all the data can be shared, that is a huge win. And if you can make sure it all gets downloaded, that's a great thing. I hate to put more pressure on the patient. So if the systems can work, that's a really good thing that you have to think about.
And that's where the disease organizations you mentioned before can kind of help too, and perhaps even talk to each other to, if there needs to be some matchmaking that goes on to make the patient's life easier, because you do want to be seen by a specialist, but you also increase your risk of things going wrong when they're not at the same place. So it is tricky.
Yeah, very much so. And you're building these huge teams, when you're dealing then with, breast cancer, you've got surgical oncologists, radiation oncologists, medical oncologists, you've got a plastic surgeon, and, who's doing what when, and you're dealing with that on top of the myeloma. And, that's where my heart goes out to all patients, is that somehow we have become the person that has to keep everybody together and on the same page and understand who to call when. And I think that's hugely challenging.
And that's where when you do have a caregiver, someone can really help pull all those together, particularly when you're not feeling well.
Yeah, agreed.
So we will move to questions now. I do want to note for those on the webinar, I'm seeing a lot of questions that are very more treatment oriented. So what I'll do is make sure that one of our nurses in our patient navigation center gets back to you directly and keep these questions more focused on Kathy's experience and the book. So I'll start with one because we talked about caregivers a little bit, but the book in particular talks a lot about caregivers. This question, what are some key pieces of advice you have for caregivers helping myeloma patients navigate the uncertainty?
I would say speak up. So this was a huge lesson I learned when I went back through the journals. Caregivers are sacrificing a lot to help. And there are points in time where they have just tremendous burnout from trying to be everywhere for you while they're running their own full-time jobs. And yet they stay quiet because they feel like cancer trumps all and that they just want to be there for you. So in my mind, caregivers need to speak up. They also need to, if they can't handle a lot of this, they need to say something and then work with the patient to find some resources that can be helpful. And they need to encourage the patient to do what I write a lot about. Don't rely on just your partner or one person to help you through this journey. It's too much. And so you have to broaden out and get additional resources, whether it's from foundations or friends or other people that can help you. But this is not a solo journey, and it's not even just for two. It's a lot of work to do it well.
A couple of other questions about, I guess, how you're living your life, knowing that every patient is different, but it may be helpful how you feel about flying or driving when you travel. I would say both now and particularly when you were in the thick of it.
Yeah, well, this gets back to, saving your life while living your life. It is true, weakened immune systems. I do find that when I travel, I really do get sick on these planes. So I have to take the precautions, either wear a mask, and then also just make sure that I tend to overschedule, like I'm doing 10 things in a day. And so at some point you have to realize this is not healthy for any of us. So if you're going to travel, don't do your flights at crazy times and things that are going to drive you nuts, because the stress is just bad for the system. And again, when you get back into the prevention side, are you getting the flu shot? Are you getting Pneumovax? Are you getting all the things that you need to make sure that you're somewhat safe? They're controversial, of course, in some situations, but if you're over 65 and dealing with this disease, there's a lot of things that you still can do.
Another question, I love this. What's your favorite journal or go-to journal for research, myeloma, in the myeloma space?
Yeah, I would say because it's myeloma, the one that I get the most information out of the fastest, because it's constantly publishing, is blood. I mean, it's always there. You love to do the high peer reviewed journals, but you're not going to see as much information. And I feel like in myeloma, everything's changing so fast. And so that's why even when you get to webinars like this, everybody has the question I would have too is, what should I do? Like, what drugs should I take? And how should I handle that specifically? That's what I'd want to be knowing. And again, you can ask that on a webinar here, but the real truth becomes working with groups like the MMRF, and when people are contacting me all the time, it's what do I think I need? Where am I leaning, and what's going to help me make the best decision for me?
Well, there's a comment here, or a question that I think is worth clarifying about. I think a patient asking about researching drugs on her own versus, maybe she'll come up with something that's totally not appropriate. She's not a doctor. So this is where, from my perspective, but I'd love to hear your perspective too, it's important to read a little bit about the different options and about your treatment goals. So then when you go in to speak to the doctor, you'll understand you'll be familiar with what they're talking about, but they'll also be able to better guide you because they know what your treatment goals or you said some of the logistics in your life. Do you have a caregiver? How much time can you take off of work? Things like that. Informing the doctor very clearly about those things helps guide those treatment decisions.
Definitely. And I think that it's not hard to get this information anymore. It used to be hard, but as I've said before, if you take a conversation like the webinar that the MMRF did on the ASH meeting, right? And you just listen to that webinar, you would know, because it was beautifully done in terms of newly diagnosed, first relapse, and then moving out. If you listen to that webinar, and you don't have to know every single thing in the webinar, you're just listening for yourself, you will start to understand, if I'm a smoldering patient, am I high risk? What's the benefit of Revlimid? What's the benefit of Dara? If I'm actually moving earlier in the disease, and I think there's going to be a relapse issue, what drugs do you want to be on? It will walk you through all that so that you walk into the doctor's office. And again, that MMRF will give you a navigator, but even if you're doing this on your own, it's already summarized for you. And so you can go back in and say, okay, now based on this, what should I do? What should I personally do based off the personal things that come into play? So again, I think when you're in a situation like this where you're going, do I want CAR T? Do I want to buy specific? Which side effects what am I scared of? What am I afraid of here? All of that matters because these are good drugs and highly effective, and you've got multiple options. It's a personal decision. I mean, I went through the same thing in breast cancer where for DCIS, doing a double mastectomy is a very aggressive treatment, but I had a window of opportunity where if I did that, I didn't have to do chemo and radiation. That's a personal decision for me to go, I have been through enough. I don't want anymore. I'm done. I'm just going to do the surgery. Again, no right or wrong, just walking to that doctor's office with a lot of questions to try to make a shared decision with them.
A number of, I probably should have flagged this earlier, a number of individuals were asking about PCR and what PCR is, because they're probably familiar with MRD, and not that many centers do PCR.
Yeah, you don't have to worry about it so much now. It was much more of an old school effect when we didn't have all the amazing MRD testing done that you can do now. So much better to just get to your center, do the MRD testing, and it's getting so much more sensitive in terms of how deep is your response. So stick with the ones at the academic centers, not the one I just mentioned. I was just a little ahead of the curve doing MRD before MRD was something.
Yeah, and for everyone, it really was the best way to measure depth of response at that time.
At that time, yeah.
So another question, because I guess we didn't dive into this too much, how to prepare for relapse happening?
Well, again, I'll repeat myself, which is, I don't think I ever had an appointment up there at Dana-Farber where I didn't say, if I relapse tomorrow, what are we doing? And I would always ask that question when I was doing fine, when my tests were stable. And I always want to know the answer to that question. So if you ask that question and you know the answer, you're not scared because you know what you're going to do. I think where people get nervous is when they're asking questions at a time of panic, because now you're relapsing and you're not sure what to do. Make sure you understand what you would do if you were relapsing.
And there's a few questions in here too about test results, and I'll refer everyone to, we have Understanding Your Test Results, a brochure. We also have a webinar coming up in February on this topic. But Kathy, you could say, what were, the numbers that you followed?
Yeah.
In particular for patients, just to simplify it, because in your portal, you have so many numbers and things to look at.
And still what I follow, right? Yeah. So for me, it's still going to be my M spike. It's still going to be, they still actually can do some of the MRD, without the bone marrow. And then light chain, of course. But it's not crazy for people to also just look and say, well, how am I feeling and how am I doing? So, you're looking at your counts in general to just say, does everything look pretty much okay? But those are the big ones I'm looking at any period of time.
And the beauty of having access to the portal, to be able to look at those and have questions, and certainly feel free to reach out to our Patient Navigation Center to go into, if you see changes in numbers, and as you know from yourself and from talking with patients, sometimes you see one and it's a blip. If it's not a continuous change, it's okay. But to flag that, to ask the care team what's going on.
Yeah, absolutely. So I find when you're in the portal, now you're looking at everything. It's also just another click to write directly to them and say, please explain this. Because again, anything that you're putting in writing in your portal, they're going to feel very obligated to make sure these questions get answered. And they're going to be faster to return your questions and comments back. So I think the portal is an amazing tool to be able to use and to, again, prepare you for the doctor. I think as you're using it and you have more questions, then of course, call the navigators here and they'll be super helpful to you. But I think people forget how best to use the portal itself. And again, I do always say this to everybody, you have to, as soon as you see something, there's so many times I turn my portal on from any of the hospitals I'm working with, and it just has in bold, abnormal. And it can set you oh my God, what just happened? And then it's very quickly, it's another click where you just go, okay, what's the trend? And you can go back and look and go, okay, well, I had that number, 3 or 4 times before. This is not a point where I should be in crisis mode again. You've got to calm yourself down by understanding how to use the tools that are available to you.
I thought this question or kind of comment was, it brought me back to when your sister was diagnosed with breast cancer and you were dealing with your myeloma. The individual asked how much does stress impact myeloma? When she was a caregiver for her son, her myeloma numbers jumped. So I maybe perhaps talk a little bit, it wasn't exactly your experience, but managing that stress of being a patient and a caregiver, because both are unavoidable.
Yeah, I think at the end of the day, we all have to remember that stress at a certain high level is just not good for our immune systems. It's just not. So yes, of course, we're going to get sick. And they always say this, you've got to take care of yourself before you start taking care of everybody else, but it's just really hard to do. Again, I think this comes back to understanding the resources that are available to us and our ability to ask people for help. I find that I was trying to take everything on or just dumping it on my husband and my sister. At the end of the day, there were other people, when I looked back and read through my journals, there were other people that easily could have taken some of these jobs for me and would have really felt good doing it. And I think we forget to ask.
This is also an interesting question because MGUS is largely considered a benign disease. Only a small portion end up becoming smoldering to active. But this individual with MGUS was asking how much to push for a second opinion with MGUS, or are you okay with the hematologist you're with?
Yes, I think this is a personal decision. If you're the kind of person that wants a lot of information, I don't think it's crazy to at least have a discussion with a hematologist, oncologist about where you are. But you are right, MGUS, you're going to be doing fine for a really long time. So when people write to me with MGUS, I'm usually you're enjoy your time right now. Enjoy it. Go live your life. Everything's good. Don't let this weigh you down. And again, get monitored often enough that you feel good about it. I mean, maybe you say, well, I'm nervous about it, but you get monitored. They say, well, come back in a year. And you're like, no, I'm going to come back in 6 months or less. That's okay. It's okay to do that if that's what's going to make you feel better, that you're managing your disease better.
This question, we haven't really covered this topic, and I know you do have some very good guidance in the book, advising patients if they're limited by their insurance, the provider options from their insurance company.
Yeah, this is a tricky one because I had situations personally where I had to go out of pocket. And it really, you forget how much that can take a toll on you. So, my perspective is whenever you can stay with your insurance company, you've got to figure out a way to do it. At a point where you can change your insurance, that's tricky too, but put the time and energy into working on that because you don't want these out-of-pocket costs. And and I always go into this on the dental side as well. Like there's so much preventive work that can happen because all of these drugs and transplants, they just do a huge number, and all of that is out of pocket, and it takes a huge toll too. It's not managed properly.
Another topic we get this question a lot that is really, really tricky, asking for, I would say, either a second opinion or switching doctors within the same center, and how to do that when some people can be pretty insensitive about that, I would say.
I think we have to get over that. I honestly think that as patients and caregivers, we have to get over it. It is much better if you, and I do write about this in the book, where, I had one doctor I was working with. It wasn't he was doing anything wrong. We just weren't connecting. And so it was the nurse who recommended that there was another doctor in that practice. It would be great by me. If that practice is nearby and it's convenient and they have overall good reputation and you just didn't mesh with one person, it's okay. You're simply going to the front desk and saying, I'd like to switch. You're not looking the guy in the eye and saying, I'm leaving you. You can do these things in a diplomatic way and just say, I'd like to do a switch. You'd be surprised how easy it is. And, a few appointments in, you're not even thinking about it anymore. It's so worth doing if this relationship isn't working for you.
And then just a couple final questions before we'll need to bring this to an end, that are, again, very relevant to or similar to your situation. And we covered this a bit, but what advice, this patient is asking, what advice do you have for being in remission, whether on maintenance or not on maintenance, but waiting for it to relapse? She says her brain won't stop.
Yeah. Okay. I always say to people, the biggest regret you're going to have is if you relapse and you didn't do everything you wanted to do. Like I look at relapse as saying, okay, and I always write this down. I'm like, okay, pick your North Star, right? And so in the book, if you read that, basically my North Star was to have another child, the greatest gift ever in my life. And, now I have 2 children, one's 31, one's 28, and it's still the greatest gift in my life. But I also said, and to create the best family memories I can. And when I look back, I was working so many hours and doing so many things. I missed out. So I'm not going to do that again. Like I literally will sit down, and I talk about this a lot on social media. I will sit down and say, okay, well, what is my North Star? How do I want to spend my time right now? How do I want to spend it? And who do I want to spend it with? And I will start carving that out so that when other things come up, I'm not doing them. I'm doing what matters to me. So you've got to put that stuff out of your head, because I can promise you the worst feeling you have is you relapsed and you go, oh, shoot, I didn't do this. That's just a terrible feeling. So go live your life.
So one question again, and I think for those who haven't read the book, this will be helpful. I'm asking what the portal is.
Oh, the portal. So on your medical portal, whenever you go to the doctor, whatever hospital they're affiliated with, you're always, at least these days, you will always get an email saying you need to be signed up and have given permission to be on the portal. And that is where all of your test results are now coming. So, there is inertia of portals. Like we all have them and we have multiple ones and they don't talk and they have different passwords and they all work differently. And there's a lot of inertia to using a portal. But once you figure it out, it is a wealth of information for your test results and your constant communication with your doctors in terms of insurance coverage, appointments, prescription refills. But even if you have a question about your care or test results, like we talked about, your portal's your friend. You just have to learn how to use it.
And you have a good point too about writing the question in the portal. Then you have the answer, or one, they're accountable for answering your question, and two, you have the answer in writing.
Yes, absolutely. You can also write into the portal, I've called twice and nobody's responded. Somebody will get back to you.
Well, that's all the time we have for questions. Rest assured, because there were a lot of others, and a lot of them were asking about the title of the book, and I will get to that in our closing remarks. We'll make sure that a lot of these other questions that were more medical in nature are covered. But
yeah,
again, thank you so much, Kathy, for your time, and for the audience for listening. Kathy, your wisdom is always such a gift to the entire community. And there's so many comments here that are so wonderful, saying thank you for sharing your story. Thank you for writing the book and asking about how to access it. I mentioned too that I would cover the additional resources that the MMRF has. There was a question on this in submitted as well. We have myeloma mentors who are trained patients and caregivers who have lived with this disease for a number of years. They share both their personal experience and helpful resources. The beauty is we have about a dozen mentors, all different ages, genders, geography. They've been through different types of treatments, different life experiences, so we can really match you with the one that's going to share your characteristics best. Also, I mentioned this a few times during the webinar, and for those whose questions weren't answered, I'll make sure that someone from our Patient Navigation Center follows up with you. We have 3 trained oncology nurses who I think were at the bedside of patients for more than 50 years. And no other organization offers former nurses who will answer every single question you have, spend as much time as you possibly need, preparing for those doctor's visits, preparing for changes that could come along your disease journey. We also offer dozens and dozens of educational programs. We do monthly webinars on the last Wednesday of every month. We have videos, we have podcasts, we have brochures. You can find all of it at our website, www.themmrf.org. The Educational Resources Hub is really the place to find all of the different multimedia options for you, for patients and caregivers. In terms of upcoming patient education events, we've tried to roll out the webinars to start with how to prepare for visits, how to understand your test results before we move into more of the hardcore treatments. The next one being understanding first-line therapy, induction, transplant, maintenance. Those are coming up in February and March. You can visit our website for the complete listing and also register for these. For those of you who are interested in becoming involved with the MMRF outside of educational programming, we also offer dozens of event-based fundraising opportunities as well. We have walk runs, and then for patients, but largely for caregivers, we have half and full marathons. We climb mountains. You can do bike rides. So really a lot of different ways for you and your loved ones to get involved. You can create your own fundraiser, and we've had everything from canasta to golf tournaments to bingo nights, even lemonade stands, so that the options really are limitless. And then for everyone asking, again, the name of Kathy's book is Fatal to Fearless. You can purchase it really anywhere, online, in bookstores. Kathy also makes her 12-step checklist available for anyone if you register on her website. Kathy posts almost several times a week on all of her channels as well, particularly Instagram, Facebook. There's a lot of content, and even those on LinkedIn, there's content there too. So certainly check out the book, but also follow Kathy because she's constantly adding new information as well across all of her social channels. Again, a reminder about the resources. We have an evaluation form. Please do fill that out at the conclusion of this webinar. You can look at our bios again. There's a copy of these slides. There's the exhibit hall with additional resources from the MMRF, as well as our sponsors, Kite, Arcellx, and Per Magazine. Again, thank them. We are so grateful for their support so that we can make these educational programs available at no cost. The slides and recording will be available on our website in the next couple of days. And again, please do fill out the evaluation form because it helps us inform content for both future webinars and other educational programs. So that's it for today. Thank you for joining us, and we hope to see you again in the future.